Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. My guest today is one of my favorite people in the healthcare domain, Jay Fisher. I've known Jay for a number of years. He's a partner at C3 Partners. C3's focus areas include management consulting, healthcare AI, and MACRA software, and really clarification and guidance. Jay, thanks for joining the Tate Chronicles today.
Well, Jim, I'm flattered to be asked.
You know, the topic for today is the MACRA program. Jay, I know you've been through thousands of pages over the years of the regulatory documentation, answered hundreds of questions since this MACRA baby was born. So thanks for being willing to come on the show today and answer a few of my questions. I really appreciate it.
Oh, no problem. I mean, we do read through every federal register that comes out with MACRA, and I can do a job.
I'm glad you do that, Jay. That helps me claim a little time back to my life, so I don't have to do it.
Which but boss get to cherry pick, and I choose to do that one. So.
But in a nutshell, what is MACRA, and where did this creature come from? Let's go all the way back.
Well, all the way back, it kind of is an offshoot of an old program called Meaningful Use that Congress and CMS had. And the goal of both Meaningful Use and MACRA were to help reduce government costs of Medicare program while sustaining quality. And what MACRA has done that's different is in Meaningful Use, it was sort of a checkbox. You just said physicians would file information and said that they filed, and that was all there was to it. What MACRA did was it created scorecards. And then tied a physician's score to their Medicare reimbursement. So the better your score on MACRA, the better your Medicare fee schedule adjustments are.
And to my understanding, the MACRA score you talk about, this is a annual score that is achieved or calculated. Of course, the algorithms can be exceedingly complex, but for either individual providers, or it could be for a number of providers that are in a tax ID number. And the reimbursement, to the best of my understanding, is that there is a baseline reimbursement, and based on your MACRA/MIPS score, you can get a positive adjustment or negative adjustment. So it's carrots and sticks.
It's carrot and sticks. And interestingly, the way Congress set up the program is that it's they refer to it as revenue neutral. And essentially what that means is that Congress expects some of the physicians every year to have poor MACRA scores and get penalized. And those penalties fund a pool of money that gets reimbursed out to those providers who have good scores and rewarded. So the more penalties that are incurred, the more money there is available to pay high performers.
It's funny, of course, the government entities in this don't like to use the word penalty, so they call it a negative adjustment, reimbursement adjustment.
Very clever.
Yeah, it is clever. Well, they make the big money. But the range of how much you can have a positive adjustment as opposed to a negative adjustment, the maximum minimums there, that has changed over time. Where are we now with all that, Jay?
Well, in the early stage, the negative adjustment was fairly small, but for about the last 3 years now, it's at the maximum of 9% negative adjustment. Of course, the positive adjustment, like I said, it depends on how many physicians are penalized or receive negative adjustments themselves in a year. And the reality to that program is, so if you do nothing at all in MACRA, you earn a 9% penalty. In other words, your Medicare fee schedule for a full year is reduced by 9%. But the reality is that CMS made the program fairly easy in the first few years, so that the thresholds to achieve positive adjustments were pretty low.
Mm-hmm.
And the rules had a lot of loopholes and relaxations in them to make it easy. The upshot of that was through about 2021, even though there's a lot of, I guess, noise around MACRA about how difficult it is and how expensive it is, through 2021, from 2017 through 21, never had more than 3% of the physicians in the country been penalized. So, to put that number into context, when Congress created the program, they built the program such that every provider who scored below an average would be penalized. Well, CMS held the average artificially low for a long time. Long term, CMS expects and Congress expects that roughly half of the providers in the country are going to be penalized in any given year. The context for that statement, in 2020, so when you read the Federal Register, far in the back pages, there's an assessment that CMS publishes each year that says how many providers, what percentage of providers they expect to earn penalties. For 2022, CMS expected for the first time ever that about 30%, maybe 33% of the providers would get penalized. In 2023, they projected 30%. And they haven't yet published, I haven't seen the 34 numbers. My guess, personally, as I look at trends and how people are scoring, I'm guessing that 2024 is going to come pretty close to that 50% number. Now, this is still a big surprise to people because the 2022 scores and penalty percentages were really just published about a month ago. So this is all new information. This penalty is a big surprise.
And so part of to me, black box aspects of this, Jay, maybe you can answer for me. And so if, what do we say, only 3% of providers were penalized, well, some of those providers perhaps maybe were in a rural area, or they're not doing a lot of Medicare reimbursement. But then and so if they get penalized, they're losing a percentage of not too large a pile of money. But if you have a giant Medicare provider, maybe doing a lot of procedures or things like that, and is billing quite a bit, and they're able to get the maximum positive adjustment to be zero sum, they're going to have to be a lot of folks who are penalized to make up, for the large Medicare billers who have a positive reimbursement. How does that work out?
Well, you're absolutely right. Is that in general, the smaller providers tend to have a harder time of it. We can get into a lot of the details, but probably the core idea comes around how providers report quality. And those providers who have bigger volumes of patients have an easier time coming up with enough patients to come up with to have a quality score that's really representative of their practice. If your patient volume is too low, you just don't get enough patients in your quality measurement engine to really evaluate how well you're doing. And the way the scoring system works, those guys end up with lower scores.
I'm glad you mentioned quality, because we don't have enough time today and go into extreme detail of each one of the categories that makes up somebody's annual MACRA MIPS score. But we know the category that has the biggest footprint is quality. And so there's certainly to do well in this program, it's not only to take care of your patients well, but it's also to report quality measures that are, quote, high value. And so, decisions are made on a provider or 10 level about what quality measures to report. And unless there's some expertise making those decisions, you can kind of be shooting yourself in the foot.
Oh, absolutely. I think the biggest impact that any physician group has on what their quality score will be is the decisions they make at the beginning of the year on what measures they will choose to report.
Mm.
Because there's depending on whether the provider's reporting out of their EHR or through a certified registry or one of the other couple of methods, there's a little extra not really work the physicians have to do, although there's a little of that, but it's work the administrative staff has to do in attaching quality compliance codes to every claim. And that can be a fair amount of work.
Well, and as you mentioned, smaller practices may not have the necessary expertise as to a large surgical practice that can essentially have somebody who's full-time working on this. What services do you provide relative to the MACRA program? What do you do for folks, Jack?
Well, what we found that people value the most, it depends a little bit on the size of the practice and the character of the practice, but the bottom line for almost all of them is information. It's what do we have to do to achieve the best scores with MACRA. So our core offerings are around MACRA optimization, which tends to be quality centric. What are you doing on quality? But we also help with the interoperability components, and we help with cost a little bit. So it's generally all about how do we make the score better. And there's a couple tools and methodologies. We're certified as a CMS certified quality registry. We've got a couple of AI products that help automate that process of fixing.
Yeah, and so is this that MACRA monitor I've heard talk about that you have? It's a software application.
The MACRA monitor is our core software tool. One of the things that we think is very important, and I'm a little surprised I don't see more of it in the marketplace, is that providers can get worried about MACRA and what their scores are, but most important thing is to take the scores that you're earning and convert those scores into a financial statement. And I think that's one of the weapons that we use to help our clients to make a decision how much effort to put into MACRA, right? I mean, if the most money you're ever going to make or lose on MACRA is $5,000 or $10,000 a year, well, don't spend 12 trying to fix it.
Sure.
Otherwise, or if you've got $1 million on the plate, well, then you better it's worthwhile focusing even a full-time person if you have to. So that financial piece is, I think, unique in terms of what we provide. Certainly, there are some other smart players doing that, but I think it's probably the context within which providers should be evaluating their MACRA activity.
If you're just joining us, I'm Jim Tate, and on this episode of the Tate Chronicles, I'm speaking with Jay Fisher of C3 Partners. Jay, one thing I'm interested in is when this whole reimbursement scheme was launched, there were 4 categories. One of those categories is cost. Now, we were always told in the early years, don't worry about the cost category. You don't need to do any work. The government will figure all that kind of stuff out, as opposed to like quality measures. You need to make sure you're selecting the right ones and you're reporting them in the right way, all those things. But there's obviously something new about the cost category. What can you tell us about that?
Well, do you have an hour or two?
Well, we've got about 12 minutes. So
yeah, cost was, if you go back, it's the main reason that the government needs to pay attention to this, right? I mean, cost of healthcare is very high.
Mm-hmm.
And of course, if you focus on just cost, you can reduce the cost, but you're going to compromise patient care and quality. So CMS has built a program that I think does a reasonable job of balancing those things. And there's some things they did good with it. Unfortunately, I don't think that the way that CMS measures and communicates cost creates an environment where physicians can impact their own cost or even know about what their cost is. And prior to 2022, it really didn't matter much. I mean, 2019 and 2020, cost was either re-rated totally off the page altogether, and because of pandemic, CMS said it's, we can't really hold people accountable for it. Prior to that, cost was just a couple of percentage points, but in 2023, some providers cost came in at 30%. And that there are, you talk about the law of unintended consequences. The problem with the cost program is that CMS calculates cost on Medicare claims, and they do it in the background. And the reason they have to do it in the background is the way cost works is, let's say Dr. Tate is a primary care doctor and he's seeing patient J, and patient J has an inpatient admission. Well, Dr. Tate may recommend that J goes to the hospital or not. J might go to the hospital apart from Dr. Tate. But once J has been attributed to Dr. Tate for that inpatient admission, all of J's costs, from the hospital visit to the radiologist to the surgeon to everything else, gets attributed to Dr. Tate, even though Dr. Tate had nothing to do with anything other than maybe the initial diagnosis that caused J to get in the hospital. So Dr. Tate's records have no way of knowing what are the costs associated with J because they're across a whole bunch of other providers. And Dr. Tate doesn't even necessarily know until about June or July, after the close of the fiscal year, that he was attributed J for a cost category. So it's, I think that, that part of the program really needs some thinking and some adjustment. I understand the theory is that there's, primary care gatekeepers that can influence where a patient goes or what services they receive, or, finding efficient deliverers of care. But the way the program works, it doesn't quite do that. AMA and the AHA, the American Medical Association, and the Hospital Association, have published very insightful papers back to CMS requesting and suggesting improvements in the way the cost program is structured. It's necessary, but the current structure
I understand.
Really do.
I understand. Efficiency. One of the things I often hear about is if somebody goes to their primary care provider and they've had a lower back ache for a couple of days, from a medical standpoint, it's probably not appropriate to send them for a very expensive MRI, immediately. And so, to get away, especially radiographic imaging and scans are typically high ticket billing items. Some way to rein in that automatic thing of, well, let's just immediately get a scan on everything, Let me jump to a couple other topics before we totally run out of time. The biggest question, has the MICRA program improved patient care?
Well, I think we have to ask our physician friends.
Yes.
My gut feel is that I don't think it would have had a big impact on patient care. Although the one thing that I would say is, the quality program is the quality part of the program is kind of a counterweight to cost.
Yes.
Right. For every MRI, that you try and avoid, there's a quality measure that says, are you avoiding MRIs inappropriately?
Right.
And I think that what has happened is I've watched quality over the years. It's kind of to get the old, the old saw that what gets measured gets managed. And I have
Mm.
seen for almost every single quality measure that the physician performance on quality measures across the board has improved.
Hmm.
So
Hmm.
if you believe that that the quality measurement system that we use today is truly an indicator of physician quality and physician quality is an indicator of patient care, then you would have to say, yes, there has been some incremental improvement.
Hmm.
But has it moved the needle from care for fee for hours as opposed to fee for outcomes? No, not at all. I don't think so.
Well, and so uh, providers who are eligible and involved with this, I know there's data like quality measures that are submitted. There are other things that are attested to. And the number, whether you score 0 to 100, you score a 35 versus an 85, it really matters. Um, have there been any audits of things providers have attested to or their data? Have there been any audits yet?
I haven't seen any.
I
I haven't
haven't
seen
either. I haven't either.
of providers. I believe that they're out there, but not quite to the extent they were back in the days when you and I were doing meaningful use together.
Hmm.
I do know that the certified registries, the companies that calculate quality on behalf of physicians, I have seen a number of audits of those organizations.
Hmm.
And in that case, the data that ultimately ends up getting audited is physician data. So, sort of indirectly, there have been some. Um, but as of yet, I don't see big audits hitting provider groups trying to evaluate the accuracy or the validity of their submissions. Not yet.
Yeah. Well, once they, tug on that thread, you kind of worried the whole sweater may unravel. I mean, the auditing would be very, very difficult and complex. No doubt about
It's
that.
difficult and complex. And then once you find a flaw, what do you do about it?
Exactly.
How do you go
Exactly.
about recruitment would be much harder in this environment than it would in an environment that had a different payment mechanism.
Yeah, that's true. If someone maybe doesn't want to become a super expert in MACRA MIPS, but they do want to keep up to date with changes to the program going forward, where should they look or what resources are available to kind of keep up to speed with things?
I think there's a couple. Quite honestly, CMS has done a good job on their website around
Hmm.
MACRA. It's QPP.gov, I believe is the name of the quality payment program.
Yes.
It's pretty darn good, and there's a good help desk. I think the other resource is CMS publishes a list. It's on that website of certified registries. And CMS, one of the things that in order to be a certified registry, an organization has to stay knowledgeable. They have to participate in monthly informational meetings with CMS, and they have to commit to providing education and feedback to their clients at least 4 times a year. So the community of certified registries is quite good. I think there are some consultants out there as well,
Hmm.
uh, but the only certification that provides kind of a third party validation is the CMS certified registry. And again, I think it's good. I think that process is pretty darn good.
Well, if our listeners want to find out more about your services, consulting, software tools, where do they go to find out more, Jay?
Well, our website is macramonitor.com.
Okay, thanks for that. Um, one of the things back in the, kind of final comment on my side, I'd like to hear what you say about it. You mentioned earlier that you and I became acquainted and worked together during the early years of meaningful use,
Yeah.
where the federal government shelled out, I don't know, tens of billions of dollars to help providers adopt certified electronic health records and then achieve meaningful use. And so the regional extension centers were formed and funded by the federal government. And I believe, and this is not only to, help selection of EHRs, but then like per provider, the regional extension centers got, I think, close to $5,000 per provider to help those folks, provide expertise and knowledge and consulting to get them to achieving meaningful use. I'm not aware of anything like that on MACRA MIPS program. As you say, there's great information on the internet, but there certainly is no funded entity that's going to come in and help folks.
No, there's not. I mean, the regional extension centers, that's kind of a blast from the past.
Yes.
That was, I thought that was a good investment that the government made, particularly on behalf of smaller providers. But there is the closest analog to that today would be the certified quality registries.
Mm-hmm. Gotcha. Hard to believe, but the time is, as they say, Jay, grains of sand through an hourglass, and our hourglass, all the sand has kind of run through it here. So to our audience, thanks for joining me on this episode of the Tate Chronicles. And of course, I offer a special salute to my guest today, Jay Fisher. Jay, thanks for coming aboard today.
You're very welcome. Thanks, Jim.
You can find more information on this show's program page at healthcarenowradio.com. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.